Good morning, good afternoon and evening to you all. My name is Evelyn Holmes and I'm the Education Coordinator with ISQua. Welcome to this ISQua webinar entitled Health System Recovery, Lessons from the 2014 Ebola Outbreak in West Africa with Dr. Edward Kelley, Dr. Sham Saeed and Professor Benedetta Allegranzi. The West African Ebola outbreak crippled fragile health systems in 3 affected countries of Guinea, Liberia and Sierra Leone. This webinar will identify the early recovery strategies applied in the 3 affected countries to build back strong health systems. We'll highlight successful infection prevention and control strategies applied in the affected countries to improve quality of health services and patient safety, and share lessons learned in the Ebola outbreak for use and application in other health emergency settings. I am delighted to introduce today's speakers to you. Dr. Edward Kelley is Director of the Department of Service and Delivery and Safety at the World Health Organization. In this role, he leads WHO's efforts to strengthen the safety, quality, integration and people-centeredness of health services globally, and is the lead for WHO's work on strengthening health systems and security. Dr. Sham Saeed currently serves as coordinator for a new WHO initiative on universal health coverage and quality of care being spearheaded by WHO's Service Delivery and Safety Department. And Professor Benedetta Allegranzi is a specialist in infectious diseases, tropical medicine, infection prevention and control, and hospital epidemiology. She currently works at the World Health Organization headquarters in the Service Delivery and Safety Department as the Coordinator AI and the Technical Lead of the IPC Global Unit, including the Clean Care is Safer Care program. Today's webinar will take approximately 35 to 40 minutes and there will be plenty of time for questions. Please type your questions into the chat box and remember to include your name and what country you represent. I will now pass you over to Dr. Kelley, who will start today's webinar, so enjoy the webinar.
Greetings, colleagues and friends, and thanks to ISQua for asking us to join from the World Health Organization for today's webinar. The webinars themselves offer this unique opportunity for the ISQua community to learn about a whole range of issues that are often, too often, not dealt with, in my own personal humble opinion, in our regular day-to-day work and in traditional education and training courses. And this particular one is a bit different. Most of you seeing the list of the webinars and familiar with work in quality and quality improvement would not be expecting the issue of outbreaks and epidemics to be on a curricula of webinars for an organization like ISQua. But I hope by the end of this session, you'll be able to understand why, at least at WHO, we feel this question of quality and safety within health services is core to the global community's ability to react to outbreaks, to respond to them, to build back after a major disaster like the Ebola outbreak, but even more importantly, to better prepare for the future. The work that we've done in terms of response and the reform of the organization has been substantial. WHO has just launched a new emergencies program with our colleague Peter Solomon joining from UNICEF to head up that program. But the fear that the world community would have and the member states that WHO works with is that without a substantially different approach on responding to epidemics and to outbreaks and to emergencies more generally, we will still get just the same results. The clear lesson from the Ebola situation, and we're dealing with this because this is the current topic at hand. We have good data on it. We can talk a bit more about it. But you could be replacing Ebola with Zika or with yellow fever, which is the latest work that WHO is responding to, particularly in Nigeria right now with our Nigerian colleagues. That without a substantially different approach to responding to these types of outbreaks, which will continue to happen, we will get the same results and still be in the same situation of having to make massive mobilizations to respond. In the Ebola outbreak alone, and our colleagues will deal with this, we had just over 28,000 confirmed, probable, and suspected cases in Guinea, Liberia, and Sierra Leone, and we'll concentrate our discussion on those three countries, although they weren't the only ones affected during the time period by Ebola, with about 11,000 deaths. Now, by contrast, each of these countries faced huge challenges in terms of responding, but it was not because they lacked enough personal protective equipment, PPE, for those of us who spent a lot of time with this, in these countries in terms of responding. The conventional wisdom, what has now become the conventional wisdom, is really around the role of health systems, weak health systems, to both detect, but more importantly, to redeploy and shift both human resources as well as other resources in order to be able to respond. And I think one of the things that my colleagues, Sham Syed and Benedetta Allegranzi, I hope will get across to you is that in the end, this is a technical question, there's a strategy question, there's most definitely a people question from both the community side as well as the health workforce side. But in the end, we need to look at these strategic questions of realigning and coming at health security and emergencies from a health systems standpoint. So the issues that we'll take you through, first in terms of some of the questions on recovery, and then some of the issues on the particular question of infection prevention and control, will show how we feel like this safety issue, and IPC in particular, is at the core of broader efforts to strengthen health systems, which will give us more resilient communities as well as better outcomes in the future. So without further ado, and that brief introduction, I'd like to turn over to my colleague, Sham Syed, to take you through some of the details on that first subject.
Thank you, Ed, and greetings to you all. It's a real pleasure to be a part of this ISQua webinar, and as Ed has highlighted, it is perhaps somewhat unique to have a webinar focusing in on recovery and IPC within the context of quality health services. So the webinar objectives, as you well know, are threefold, and my section in the next 15 minutes will focus in on Objective 1 and Objective 3. And I'll aim to take you through three specific parts of this webinar. First, a snapshot of what happened in the Ebola-affected countries, and it will be a snapshot in the interests of time. Second, a focus on some core concepts and definitions, which I think it's important for us to consider. And third, touching on 7 reflections from the experience that may have application and relevance to other settings. So let's start. What happened? As Ed has highlighted, we could take a very technical approach to this. We could take a very strategic approach to this. But perhaps most importantly, we need to take a people approach to this. So the Ebola crisis, as we all know, was the focus really should be on the human suffering that occurred during the Ebola crisis. And that is in terms of mortality and morbidity, but huge ripple effects in society in each of the 3 Ebola-affected countries and beyond. At the height of the Ebola crisis, and we see these maps from Q4 of 2014, while the response effort was being taken forward, there were a few of us that were involved in recovery planning. And maybe the question, well, not maybe, actually the question did arise at that time, whether this was the right thing to do. Of course, in the crisis mode, one has to think about beyond the crisis, and that was what WHO and other partners were doing at the time of the outbreak. And even back in the summer of 2014, the fact that severely compromised health systems, significant deficits in capacity, and rampant fear were highlighted in the Ebola response roadmap that was put forward in the summer of 2014. But let's go right to the Liberian front line. And in the summer of 2014, working very closely with some of the hospital leads. This is Dr. Francis Kate, who led one of the main hospitals in Liberia at that time. And I asked him a very simple question during that summer. If he were able to plan for this moment 3 years ago, what would he have done? And I recall the fivefold response. First, building a strong primary healthcare system with infection control and patient safety embedded within the system. Second, really focusing in on the trust through community engagement, focusing in on a supply chain of essential supplies, but also developing a cadre of IPC and patient safety officers for the future. And finally, focusing in on strong, safe service delivery as the basis for preparedness. So this was a hospital leader emphasizing what he would have done 3 years before the event to have been prepared for the crisis that he had to face. This gentleman is now the Chief Medical Officer of Liberia. At the same time, the WHO Strategic Response Plan was being put forward, and the third strategic objective was safely reactivating essential health services and increasing resilience. And let's just touch, and this is actually just touching on two of the resilience and recovery plans. This is the health sector recovery plan from Sierra Leone. And as you can see, and importantly, some of the key building blocks, the patient and health worker safety outputs, the health workforce outputs, the essential health services outputs, the community ownership outputs, and the surveillance and information outputs. And you can see also that and I'd like to just make a specific call out, that you see that patient and health worker safety is one of the 5 big pieces in this jigsaw puzzle, and articulating 12 key action areas within that area, and in fact making sure that infection prevention and control is at the forefront of this effort. And clearly you'll hear greater detail on that from my colleague Benedetta Allegranzi. You can also just touch, and we can only touch in the interest of time, the Liberia investment plan for building a resilient health system. And here, emphasizing that the 3 building blocks of that resilient health system plan, one is access to and utilization of safe and quality health services. Second is emergency risk management, and a third is appropriate enabling environment. Many details underpinning that, but emphasizing here that access to and utilization of safe and quality health services was considered one of the 3 main building blocks of this investment plan for building a resilient health system. So with that in mind, let's just come to a few key concepts and definitions in the second part of this webinar. So it is important to understand that the phases, while often they're spoken of in separate terms, are of course heavily interdependent. So when I was mentioning the outbreak situation, of course, that was at the time where WHO was heavily focused on the aim to get to 0, and rightly so. But at the same time, and overlapping this, it was the early recovery phase, which then would overlap with the recovery phase, and ultimately, of course, blend into a functional health system. Now, these demarcations are, of course, artificial, but this, coming from the Sierra Leone plan, emphasizes that all of the phases somehow are, of course, interrelated. And while getting to 0, one has to consider early recovery and functional health systems. It's worthwhile just considering just a couple of key definitions. This is the definition of early recovery that we were using at that time. And the key point to emphasize here is that health and quality health services sits within a broader and wider context of development. And it is sometimes a fault that we have in terms of drilling down too quickly on a granular level of detail on specific subject areas, while not perhaps taking a full appreciation that the restoration of basic services includes livelihoods, shelter, governance, security, rule of law, environment, and social dimensions. So this is where our work sometimes needs to fit, of course, within a wider context of development. Many of you will be very familiar with the definitions of preparedness and resilience, but it is important to emphasize that these definitions are critical to consider, especially because there are interface points and there is a blending sometimes of these concepts. Here you will see two definitions, one of preparedness and one of resilience. I'll let you examine those and to see how they blend together. And at the same time, it is important, while recognizing that everything cannot be connected with everything, it is important to understand that each of these Ebola-affected countries had a clear pathway towards universal health coverage, at least at the conceptual level. And as many of you will know, the concept of quality is embedded within the concept of universal health coverage. And as you will have seen from the two resilience plans that I shared, universal health coverage was emphasized in each of those two plans. So how does that all come together in terms of conceptualization? We can see that many of the services and the systems that we were tackling were of poor quality, inequitable, fragmented, and lack of services. And when we see that service delivery is moving towards developing resilience, we recognize that within the Ebola-affected countries, there was a clear shock which led to decrease in service delivery in terms of both utilization and the level of trust within the community. And this here explains how WHO in their recovery effort was aiming to support the countries recover, but also to move forward on their trajectory towards resilience. And the four core components of the work on recovery involved IPC and patient safety, health workforce, essential services reactivation in a broader sense, and the linkage between surveillance and wider health system underpinnings. In the third part of this short webinar session, I'd like to focus on 7 reflections that have a broader significance and application elsewhere. First, point 1. One of the things that we have emphasized, and actually Ed has already alluded to, is the need to link the global drive on any issue, specifically global health security, with local action. So there can't be no global health security without local health security, and that local health security is heavily dependent on the quality of service delivery. And while many efforts, and the Ebola Recovery Assessment, which is available online, was an attempt at taking a wide look at the needs related to Ebola recovery across the 3 Ebola-affected countries, one can see that once it gets to the global level, sometimes you lose the granularity and the drive from the local and national level. And this is where the action really is. So point 1, making sure that global drives are heavily linked with local action. Point 2, we faced an issue of having to respond to multiple technical requests, and there is a clear need to streamline technical resources in the recovery phase. WHO had to respond very quickly and developed a recovery toolkit, which can be utilized now in any country that's facing a crisis situation. The purpose of this recovery toolkit is to support countries in the reactivation of health services which may have suffered as a result of the emergency. As you will see, this is something that was developed for Ebola-affected countries, but has relevance to many countries that are facing recovery situations. Point 3, this is something that was highly evident, and I think but my colleague Benedetta will go into a little bit more detail on this, but it was critical to focus on the structures for quality and staying concrete. So clearly, water, sanitation, and hygiene, just as one example, is critical for achieving public health goals. And there is definitely moves, both in the Ebola-affected countries and elsewhere, to ensure that discourse on quality, discourse on universal health coverage, discourse on recovery somehow takes into consideration the critical structures that are required. Point 4, and this is something that is one of the biggest lessons for us, is drive integration between health security and health systems. At the point of delivery, it's actually the same people that that look at new communicable diseases emerging within the facility, and in order to prevent, detect, and respond to those, it's the same health worker that has to vaccinate, that has to be an active part of the surveillance system. So how do we ensure that linkage between health security and health system is maintained? And that is something that is a big lesson for us, and we're moving forward on further work on this beyond the Ebola affected countries. Point 5, already touched on, but a critical point: strengthen community engagement for quality in the context of UHC. Community engagement is, of course, key to quality, and it's more than just social mobilization and information dissemination. It really does need to focus in on long-term systematic processes for community engagement at the clinical level, at the institutional level, and also within the heart of the community. So effective engagement for quality requires capacity of staff to engage. So this is a hugely important issue. Linkage of the micro and macro systems, it becomes incredibly important for that to have real teeth at the front line. Point 6, making sure that national quality efforts are catalyzed through the recovery and resilience planning. We have seen in all the Ebola affected countries moves towards national quality drives. For example, the Liberian effort has now morphed into an effort to develop a national quality strategy endorsed at the highest level. So this is a clear lesson for us, is that we need to ensure that the national quality strategy and policy is heavily linked with any effort at preparedness and resilience. Point 7, final point, but a critical one, is we need to emphasize the importance of district management for quality in the context of UHC. It's vital, and it's also vital, again, related to IHR compliance, and it is critical for this to be considered in the context of adequate resources, and here the link with health financing becomes very clear. So bringing it all together, WHO is moving forward with some thinking on how health system strengthening can underpin efforts at universal health coverage with quality embedded within that. But you will see here that the ultimate result that we're looking for is global public health security and resilient societies. And to end with the words of President Ellen Johnson Sirleaf, it's clear that the long-term investment to build health systems to prevent outbreaks of this scale from ever happening again is the destination that we're looking for, but that takes sustained effort, that takes sustained eyes of the world when the headlines no longer are mentioning the Ebola-affected countries. Thank you very much. Look forward to the questions and answers at the end of this webinar. If there's we can learn more. It's a very short space of time to give you a briefing, but we hope that you'd be able to look at some of the WHO web pages. But again, thank you very much for your attention.
Thank you, Shams. Professor Allegranzi?
Yes, many thanks, Evelyn, and many thanks to ISQua for really providing us with this very good opportunity to share our lessons. Following on from my colleague Shams, I will try to give you some very practical examples of how we faced very serious gaps in IPC and WASH during this epidemic, how the countries reacted to this and built very quickly a very effective response, and then how this was then reflected in their medium long-term plans for recovery and their current progress. I will start with the first point, which is a first lesson learned, which was that absence of IPC and WASH basic measures and infrastructures, both in the community and healthcare settings, led to the unprecedented situation of this outbreak. So I would like to start from a report that WHO issued last year to document the incredible gaps in terms of water, sanitation, and hygiene worldwide in healthcare facilities, in particular in low middle income countries, where you can find that up to 38% of facilities worldwide do not have improved water source, or a similar percentage do not have water and soap for hand washing, and around 19% do not have improved sanitation. So if we look at the statistics from the 3 Ebola countries, you can see that these lack of access to water, sanitation, and poor hygiene practices were problems pre-Ebola. They were clearly exacerbated during the outbreak, and also today remain problems to be resolved. So you can see here that according to the global report and other assessments, in Guinea, Liberia, and Sierra Leone, for instance, the access to improved sanitation is or was at the time 1 year ago or two less than 20%. Or if we look at healthcare facilities in Guinea, for instance, on average, the situation of WASH was appropriate only in 13% of all facilities assessed. Or looking at Liberia, for instance, only 50% of the facility assessed had adequate water coverage and availability of soap for hand washing, or Sierra Leone had similar percentages of water coverage in healthcare facilities. At the very beginning of the epidemic, CDC published this paper, which also shows very worrying information about the implementation of IPC standards. So we are talking about procedures, we are talking about appropriate triage and screening settings in healthcare facilities, and also availability of supplies. And you can see a range of unfortunate no in this table, which is related to a number of important districts in Sierra Leone where the epidemic was really prominent. Similarly, in Liberia, at the beginning or in the middle of the epidemic, at the beginning of 2015, you can see that in a number of healthcare facilities assessed for IPC, very important assets or tools for IPC, such as isolation facilities, incinerator for safe waste disposal, or even availability of clean water and electricity were either less than 40% or even around 20% available. And finally, we can see that all these gaps were reflected in one of the important indicators of safety, which was the EVD infection in healthcare workers, which WHO documented in a report published in May 2015. And you can see that we described that healthcare workers were from 21 to 32 times more likely to be infected by EVD than the general population. And overall, 4% of confirmed and probable cases of EVD were among healthcare workers. But you can see that at the beginning of the epidemic, especially in the first year, 2014, you can see that this percentage varied between 6 up to 16%. So healthcare workers paid a very high toll during this epidemic, especially at the beginning, due to the many gaps in practices and infrastructure. So the second lesson we learned in our efforts to support the 3 countries and work together in country and also globally in the coordination is really the importance of first of all, partners coordination, and then the importance of consistency and standardization of technical approaches and SOPs for IPC, in particular for the Ebola infection, but in general. So this is an example, for instance, in Liberia, how many partners and NGOs were involved in the response, and in particular had a role in improving and implementing IPC and WASH during the epidemic. Unfortunately, at the beginning, this was reflected in a range of different guidelines, approaches, SOPs, which created a lot of confusion, and in many cases, unfortunately, were not really entirely evidence-based. So the effort of WHO, together with partners actually, was really to very rapidly issue a number of guidelines or tools such as posters or frameworks in the field of IPC, but also in many other fields, such as clinical management, to really have uniform and also standardized approaches based as much as possible on evidence. This is because, as I was saying, at the beginning we learned how much under stressed and fear conditions healthcare workers and even partners and organizations can really get confused and implement approaches that are not reflecting, for instance, the transmission means of the virus, or are actually poorly evidence-based or inappropriate, such as spraying, as you can see here. Spraying, according to some IPC experts we have been working with, for instance, has no evidence in its role in preventing transmission, and also has caused serious adverse events in healthcare workers exposed multiple times to spraying, as you can see in this table. So there was a lot of focus on PPEs, personal protective equipment, which of course is important, but it's not the only measure of infection prevention and control to be applied in such conditions. For these reasons, also because in terms of the technical specifications for PPE, there was a lot of confusion and different positions taken by different organizations. We had to issue a in a very urgent manner an evidence-based guideline, which we developed together with several important partners, such as CDC and others. So, all to say that protection and IPC depend on several factors, not only on the type of gear you are wearing at the time of exposure, but it really depends on a number of different types of supplies which need to be provided in an adequate and regular manner. It depends on staff training, appropriate use of PPEs, for instance, other measures such as hand hygiene performed in an appropriate way, and finally, really appropriate human behavior according to best practices and close supervision and support to healthcare workers in such pressure and stressed situations. A concept that we had a lot of difficulty to transmit and to really be endorsed by our users was that IPC is complex and it's made of different elements, not only based on protective equipment, but many other aspects that are listed in this slide, which I don't have the time to detail, but it proved to be very difficult to integrate these different measures to finally achieve the best protection possible for healthcare workers, and also, and in particular, adequate levels of patient safety. Another element which was mentioned by my colleague, and it was an important lesson learned for all of us, was the importance of community engagement in the IPC approach. The position and the level of knowledge and understanding of the community was really key and paramount to also the level of awareness among healthcare workers, for instance, and also the cooperation by family members, by visitors to the Ebola facilities. All of this was really crucial, and these were really new approaches to IPC which we haven't experienced in the past. So now the conclusive part of my presentation is really to reflect upon the fact that this focus on IPC, which eventually was really in-depth and also very productive, this focus created the foundations for country IPC capacity building and has now driven IPC on the top of the national agendas, and I would say also very much more prominent in the global agendas as well. So my colleague Shams already highlighted the important priorities in the context of early recovery and then the development of strengthened health systems in these three countries, and how the lessons learned from the response were applied in conceiving very insightful and proactive new action plans for health systems, and then in particular for IPC, WASH, and patient safety in these three countries. So I would like to give you a couple of examples, in particular from Sierra Leone and Liberia, of what I've said, how the response really provided the building blocks for then and the foundations for then developing plans and developing new approaches and frameworks to IPC. Early in the response in Sierra Leone, at the national and facility level, for the very first time in the history of this country, IPC was established as part of health systems through a national coordination, through the development of national approaches for Ebola response, and then at the facility level through the identification of district focal points, hospital focal points, and strengthening IPC and WASH, especially in the Ebola facilities. You can see in this slide summarized the fact that during the response, massive training across the entire country on basic IPC and in particular on approaches for Ebola prevention was held in this country with a huge contribution from WHO and many others. Another example of activities during the response were the assessments that, together with the Ministry of Health, we undertook in Ebola facilities. And you can see that at the very beginning, according to a score that was established on a number of indicators, Ebola facilities were very defective, in particular the holding centers in terms of implementation of minimum requirements for IPC. And then throughout time, there was a gradual improvement up to really achieving more than 80% of this score in all the facilities assessed. And then in peripheral facilities, which are normally the most neglected facilities, you can see here that IPC assessments were undertook, and they showed that there is a lot of room for improvement, but there has been some improvement compared to the beginning, and this is reflected, what I've said, in having about 50% of facilities considered compliant with IPC standards, which gives a lot of room for improvement, but it's not really very bad, I would say, compared to other assessments I showed before. So, as I said, all three countries developed their national recovery plans where IPC and patient safety is very prominent. In Sierra Leone, you can see here a new organigram that was established last year with IPC integrated with hospital and primary health care directorates and linked to other important service delivery entities and units. And many activities and a lot of progress has been made so far with a number of evidence-based guidelines, tools, training, assessments, which have been developed with the support of WHO, CDC, and others in this country. A lot of additional training, including for managers, has been held on broader IPC concepts in Sierra Leone over the last year or so, and committees established and made functional, and also supervision and mentorship implemented, including in private hospitals, not only in public sector, and also the continuous involvement of the community, which I mentioned earlier, is key and has been taken care by the government and Ministry of Health. Similarly, in Liberia, you can see here the numbers of related to training during the Ebola response and then later on. Thousands of healthcare workers trained for the first time on basic IPC procedures and practices. And again, the organigram where IPC very well sits within the quality management unit in this country and linkages with many other essential services, directorates or units. And this is key again for integration and patient safety and quality improvement. And this is indeed reflected in this data from Liberia, which show that throughout 2015, there has been a massive improvement in IPC implementation. You can see that in Q1, only 18% of hospitals were compliant with minimum requirements for IPC, and in Q4, this number jumped up to 80%. Another key achievement has been to manage to put together all three countries in an exercise to reflect on IPC and WASH priorities as well as indicators, and the three countries came up with now 14 IPC and WASH priority indicators that are being used the same in all three countries and are being integrated in the health information management system as key performance indicators. There are many remaining challenges. Still, these countries are dependent on external support. There are still issues about temporary and inadequate infrastructures, inadequate supply chain system. After the emergency during the Ebola outbreak, it has been observed that there is a kind of healthcare worker complacency on IPC in some settings, and also there is a varying level of engagement and support of senior administration in some situations. And the challenge is being faced is really to sustain and achieve better behavioral change at the point of care in many situations. So to conclude and to summarize what I've tried to tell you over the last 10-15 minutes, I believe that IPC measures and infrastructures and supplies implementation were really paramount for a successful outbreak containment, including healthcare workers' protection. Including social mobilization and taking culture into account in IPC messages was crucial for the success in my opinion, and as I said, and this was a really new lesson learned for IPC specialists. Guidance on standards and coordination of key players were essential to achieve fast and impactful results, and these were lacking at the very beginning, but we were able to catch up quickly with this, and this contributed to progress. And the progressive leadership and ownership of key interventions by the government were key for successful implementation. So the ownership and the gradual transition of responsibilities and leadership for the IPC field, but I know for other fields, to the locals was really key. And indeed, thanks to this and other factors, despite the very serious initial gaps I told you, all three countries achieved exceptional improvements and high level of awareness of the importance of IPC and WASH. So personally, having been worked with all three countries, both during the response and now also during the recovery phase, I can say that these three countries are really seriously committed to build resilient IPC program, and also a deeply rooted IPC integrated framework aimed at preparedness for other potential outbreaks and especially safe service delivery. They continue to have important needs, however. They still need support in IPC mentorship, coordination, and technical guidance. And I think that the priority now is really to create local true expertise, which doesn't exist or didn't exist until this outbreak for IPC WASH in these countries. Local expertise, but also systems and leadership in this field. And I can also conclude by saying that facilitated by WHO, the three countries really understood the value of sharing progress and challenges among themselves and also with others, because many other countries in Africa are in the same situation, and the value of developing common approaches and monitoring indicators which avoid duplications and allow especially sharing of lessons learned. So I thank you so much for listening to me and my learning from this incredible experience during the Ebola outbreak and the recovery period we are still in. Thank you.
Thank you very, very much to all of our presenters there. Just bringing everybody back online, everybody's webcam back online, so that they can you can see everybody for the Q&A session. Okay, so we'll start off then, and our first question that we have in is from Vijay Deep Sidara in India, and Vijay Deep asks, how are the timelines decided for early recovery, etc.?
Yeah, I'll say a quick word on that, Vijay, and then ask Shams to say a word. I mean, the short answer is there's no hard and fast threshold. This is new territory in a lot of cases for WHO. In the planning with the World Bank for the official recovery process that was feeding in, each of these countries had recovery plans that were being funded both by the World Bank, and then the Secretary General for the UN held a conference to look at the fully funding those plans. There was a period of sort of, it varied from 6 months to 9 months, and for the quote-unquote early recovery period, and then a year and beyond for recovery, but they use different language. But perhaps Shams wants to add a bit more on that.
Yes, thanks for the question, Vijay. It's an important one, which I think, as Ed has highlighted, was slightly different in different situations, and rightly so. So one thing that I would emphasize is that the epidemiology of the outbreak would determine when the phases blend into each other. But that's particularly why I wanted to give the real example of Sierra Leone and how they differentiated their phases. So I think the key message to hit home on is that the phases between what we termed getting to zero and early recovery, which then leads into recovery, a wider recovery, and then health systems strengthening or health systems development per se, has to be defined by the country. And as Ed already highlighted, is that many of the global mechanisms have their own perspectives on that, but actually it's the recovery and resilience plan for each of these countries that needs to define early recovery time zones. So again, epidemiology would determine it, and secondly, the time-bound effort on early recovery would be determined by the national recovery and resilience planning, which often takes place at the height of the outbreak.
Thank you very much for that. The second question we have then is from James Oluwagbima in Nigeria. And James's question is, disease outbreak has been a key issue in underdeveloped West Africa. What is the best approach to address this, as the knowledge of the preventative measures is not new to these countries?
Yeah, a quick word on that, and then maybe Benedetta will want to take this. James, I think you're right to point out West Africa has had a particular issue with this. Obviously, this is a global issue, generally speaking, but there has been, if you look at health systems in West Africa, while a number of them have made quite a bit of progress globally, these are among the weakest in the world. But this issue of the knowledge and translating that into action is our common agenda, I think, generally in health systems, but in global health. This, how do we deliver better? How do we implement better? And it's a question of both the support systems, but as well as being able to be smart about implementation. But in terms of prevention and outbreak, perhaps Benedetta wants to add.
Yeah, well, I would really support what Ed said and say that, in my opinion, the key is to go away from the concept of reacting to an outbreak, but really preparedness and integration of infection prevention and control within service delivery as a routine, integrated approach. As Ed said, this is not easy. There are many elements that are required, including the provision of basic supplies in a continuous manner. So again, not only when there is an outbreak, but really continuous provision of supplies which are important for IPC, including water and sanitation standards. I would say that it is key also to have, underpinning all of this, to have the political commitment, national and local political authorities' commitment and will to implement and to provide support and budget for these activities. And finally, as Ed said, he mentioned the most difficult, which is really real implementation and achieving behavioral change. There are a number of approaches. Again, they should be implemented during normal times and not during emergency. They should be acquired as part of the routine. And so IPC implemented in the context of clinical procedures, application of standard precautions to all patients as it should be, will help prepare for the next outbreak. And this won't be new when then an outbreak comes.
Thank you very much. The next question is more maybe an observation that we have in from Ilamachi from Ghana. The thing about IPC has to do with more with the availability of the basic inputs like soap and water, etc. It has little to do with training. My experience has shown that in most instances, the healthcare workers know when and how to wash their hands, but what to use to do the hand washing is the biggest gap. Any comments on that?
Yeah, Elam, a really good point, and Benedetta will definitely want to add. I'll just note that obviously in this case we were dealing with slightly different than the regular. It is true Just like the basic standard precautions of what healthcare workers across the allied health professionals are taught. Here we were looking at deployed staff that were moving in, in some cases these were junior doctors who had not yet been practicing. You had new people in the field. So the training was really important because you did have that. But that being said, I was at a number of institutions, for instance, in Guinea, where I spent the most time, where colleagues working with Japago, for instance, had been doing the training, had literally been there the week before, and we showed up and there were almost none of the standard precautions being followed, and there was not even the standard precautions regarding no touching of people. I got hugged by the hospital director. So I think this is a question, like many, many things in quality safety, about behavior change. So maybe Benedetta wants to add on that.
Yeah, I mean, I fully agree with that, and also with our colleague making this comment, although personally I was really shocked by the lack of knowledge which I unfortunately saw and encountered in these countries. So I think we cannot say one thing is more important than another, in my opinion. It's true that supplies and infrastructures are paramount for IPC implementation, but sometimes being able to transfer the right basic expertise and knowledge and clear understanding, for instance, of risk assessment and transmission dynamics is very helpful. I think that knowledge is okay and sufficient, at least in my experience in these countries, about sometimes about some basic procedures such as hand hygiene, but then there are many other aspects of IPC which are not only hand hygiene or using gloves or masks, but these are much less well known, and I think that a more comprehensive educational approach for infection prevention and control is still needed, along with, of course, the infrastructure and the supplies, as you highlighted.
Thank you so much. I think we have time for just one more question. We have another few questions in, but what we can do is the speakers have kindly agreed to answer those questions outside of today's presentation. So our final question is from Dewi Indriani from Indonesia. And Dewi, thanks you very much for your presentation. And her question is, I have a question on compliance to the guidelines. In emergency situations, how can we ensure the compliance, which is already difficult in normal situations?
Yeah, really good question, Dewey. And we noted also the same point on community engagement. We'll come back to that, and actually have a team now working on community engagement related to the emergencies work. So saying happy to send you a little bit of more information on that. And I think the anthropology work on community engagement in the Ebola work is probably one of our best examples that I would talk about if we had more time. But on this, and maybe Shams and Benedetta might want to add just a brief question because we're at a point of time. But I think, again, it gets back to the behavior change. And in this case, the compliance, and in particular with infection prevention and control, we had a lot of added incentive by health workers to comply with the guidelines because of their own life on the line. And in fact, the assumption always is, I think, that compliance, we were just talking about it in another meeting, that most of safety and quality, we make the case that it reduces length of stay, it reduces readmissions, it can potentially save us money. But doing the right thing always takes more time. So, and that is the one thing that health workers have almost none of in the developing world. So I think that aspect of being able to look at job aids and other task shifting and other things will help, but compliance is a tough subject. I don't know, Shams first, and then maybe Benedetta want to make a quick point before we close.
Yeah, in the interest of time, I would just highlight a really important question, preparedness. So essentially, compliance within an emergency situation will be heavily dependent on the planning that's taken place beforehand. And the planning that has taken place beforehand, the more granular it is, the more grounded it is on actually the realities of service delivery, the increased likelihood of actually that compliance being intact within the situation of an emergency. So preparedness, but with health system and service delivery underpinnings clearly embedded within that preparedness effort.
Just a quick other comment on this issue of assessment during emergency situations. In our experience in which we led on assessments in Ebola facilities really at the height of the epidemic, the way that became successful and feasible was to use it for quality improvement. So it was, the assessments were not per se, but they were used to continue to improve the implementation of good practices, and also especially improvement of the infrastructure of the facilities. So there was full involvement of the leadership in the facility and also of healthcare workers in this discussion, looking at the data and understanding what was the plan for improvement. And as Ed highlighted, obviously the trigger was everybody's concern about their own safety, and also the wish and the will to stop the epidemic. So that was, I would say, really a trigger which you may not have in normal situations. So from this side, from this perspective, assessments in some way were even easier once this aspect was understood, that assessments were for improvement and not just per se approaches.
Thank you, everybody. Thanks to all our speakers so much for this really excellent webinar and for sharing your experiences with us. The Ebola outbreak, I suppose, is fresh in everybody's mind still, and it's a great privilege for us to hear directly from you and to learn about what you did and to control it. Thank you to all of our participants for your questions. As I said, any questions that were not posed here at the live webinar will be posed later on, and I'll get back to you with the answers. And this webinar then will be uploaded to our learning management system and also to the ISQua website within the next 24 hours. Have a good day, everybody. Thank you very much again for joining us, and goodbye.
Goodbye. Thank you very much for the opportunity.
Thank you. Thank you.